One of the chief complaints that my patient population comes in with is hunger. My patients are hungry. I have patients that are living in dual income families and they're hungry. They don't have enough money to put food on the table, and they certainly don't have enough money to put healthy food on the table. I mean, look at, we're in the heartland. We are surrounded by fields and my patients are hungry.
What if one effective solution to hunger is right in our backyards? Or more accurately, in our neighbors' backyards, in the gardens and greenhouses and small farms found in our own communities? What if, at the same time, the solution improves nutrition and keeps away some of the common health issues of food-insecure families, such as diabetes, high blood pressure, and obesity? What if access to good nutrition creates lifelong habits so that parents not only provide a healthy meal at the table, but they teach their children to do the same? And all this provides economic development for small farmers, many of whom are also living on the brink of poverty. In central Minnesota, where we piloted such a program, we learned that, given the chance, our food-insecure families prefer to choose health. Choose Health is based on simple concepts. Provide food-insecure families, many of whom had never purchased locally produced food in their lives, a share of the summer bounty provided by local growers. Using a questionnaire, Lakewood Health System identified 51 individuals or families who said they were either unable to provide meals every day or worried about having enough food to provide meals every day. Those people were matched with the fresh harvest of a consortium of small farmers, including more than 40 local growers.
A physician at Hennepin County Medical Center felt that the one thing she couldn't give her families, she could give a prescription for medicine, but she couldn't give them a prescription for food. So she started a food shelf in the hospital. And Hunger Free Minnesota became aware of this and decided to actually support that for a year to see what could be learned from that. Well, it was so promising to them that they thought, you know, it would be very interesting to know whether or not that model would work in a rural area.
But instead of doing a food shelf within the hospital, we figured that we would have better data measures and outcomes if we were able to provide these families with a CSA. They're all getting the same food every week, they're all getting the same hands-on instruction and education, and we think that we can measure outcomes better because we know the food that they're getting, we know the services that they're getting.
It was a combination of many ideas and certainly relationships on many levels. So the groups that were initially at the table were the City of Staples, University of Minnesota Extension Services. InSearch is our evaluation company that works with us on many projects. Lakewood Health Systems, a nonprofit community hospital. Todd County Public Health, Region 5 Development Commission. Prairie Bay is a restaurant that has been engaged in local foods throughout the region, and Sprout Minnesota is our nonprofit food hub. And we have a nonprofit provider, i.e. Hunger Free Minnesota, who's vested in this issue of prevention of hunger and food security. And so we had all the elements. We just had to figure out then how to get through the steps that were necessary to make it.
Hunger Free Minnesota was interested whether or not there was some kind of a relationship between people being hungry or food insecure and health outcomes. Did someone frequent an emergency room, for example, because they had issues around not having enough food to eat?
The best way to do health behavior and health education is through your provider, through your doctor. People listen to their doctor. I think a hospital has a really good role to play as far as, you know, this isn't just about, you know, you need more food, it's about how can we support your health. And I think that a hospital plays an important role in that.
Lakewood Hospital was the first hospital that stepped up and said, we would really like to embrace this program and consider how it could be modified to work here in our part of the state.
Our mission is supposed to be improving the health for a lifetime. And these kind of efforts really allow us to do those sort of things. Getting back to what really is truly our mission. and our purpose. It really gets down to, though, can you bring all the people together who are, get them focused on a common vision about making a difference. So we just have just exceptional people, and my role is how do I support them?
We know that healthy moms make healthy babies. We know that nutrition during pregnancy sort of programs infants and toddlers and then all through the lifespan. And if we can program our kids, for lack of a better term, in utero to have a healthy diet and a healthy weight and a healthy BMI, we would solve massive issues right now with our whole healthcare system. Good interval growth. Looks perfect. So this is very reassuring.
Over half of the food insecure families that came a part of this, and we had 51 that were originally screened, over half were pregnant. It'll be interesting to see, did they deliver full term? Did they deliver, birth weight, those kinds of things?
I weighed this yesterday and they're getting about 45 pounds of food in one share. This is a crookneck squash, which came from a grower over in Aiken. Cabbages came from the farm here. These beautiful cherry tomatoes and these beautiful heirloom tomatoes came from another grower, Amish grower over in Eagle Bend. Kohlrabies, broccoli, hydroponically grown romaine, cucumbers. This is kale. We had a fabulous blueberry season, so they're getting some really nice fruits this year. They're getting a full 4 pounds of green beans, and then they're getting 5 pounds of potatoes, which came from Diane and Chuck, and they grow over in Otter Tail County. For a family of 4, I don't think they'd have to go to the grocery store for much this week.
It's a dietitian's dream. I'm coming to this thing, and I have people who are excited to get a bag of produce, and I'll have people call me and say, okay, I got this thing, how do I use it? It's exciting. The woman that I was working with today, she said, my son is eating so many vegetables now, and he's having so much fun finding different ways to make it, because you can go online and find recipes for anything. So very, very engaged in that regard as well.
They're getting to feed their children healthy fruits and vegetables. I had a mom come in that said she brought her CSA share home, and there were 2 pint containers of cherry tomatoes, and that night her kids ate them all. So when they get this box from the CSA, this is like a box of gold for them.
And we make sure that we are constantly giving them touches, via text or an email or something like that. So I think that that's made it really successful.
A coordinator or a face of the program is essential, especially with families who, are going through some tough times. It's helpful to have one person that they can call or text. Carmen being the main coordinator, being the person that those participants saw from the start of the program, really helped them feel connected to the program.
Every Thursday from 2:30 to 5 o'clock I'm out here. I know everyone by name, and I have a great connection with all the families. A lot of families say that throughout this, they've learned how to cook better, they have learned how to eat better. They said they didn't know what a lot of the foods were. They said if it wasn't for this program, they wouldn't have known what romaine was, or kale, or kohlrabi, so that's been fun to see. All right, here you go.
A program like this, where it's not just about getting the food, it's getting those pantry items, those staple items that help supplement. It's getting the kitchen equipment, it's getting the cooking classes, it's doing food demonstration, it's having it in an easy to access location, it's getting the food directly to the participants.
Sometimes we focus the food around the meat we're eating. That can be the major thing, and then instead we can kind of think of planning a meal around the fruits and vegetables sometimes, and making the meat more of a complement. And the grains too, because we tend to eat too many grains and too much protein. So we're going to learn how to make a smoothie, and then with spinach and low-fat yogurt, and then we're going to make the granola, which is a whole grain, and we're going to make kebabs with cheese.
When they started the program, we gave them a bag of kitchen staples. So it had brown rice and oatmeal and olive oil, a bunch of different herbs, so that if it called for garlic powder, they had that. So we were able to actually give people some kitchen tools to make it easier to use some of the produce. So they had knives and cutting boards and that kind of thing.
Todd County is about 24,000 people. It's right smack dab in the middle of the state. A pretty poor community. We see, especially in the Staples area, close to 30% poverty. The rest of the county is about 15–16%, so Staples is definitely a high need area for the county. Our main industry is agriculture.
The food insecure families, there are 51 that we looked at, mostly female, married, 1 to 2 children. They were eligible for SNAP and WIC, and many of those were not enrolled in that, and their income was less than $20,000. Most of them did not graduate or had a little bit of high school or a little bit of college, but basically not advanced degrees of any kinds. Self-report about their food behavior and their food intake behavior was more positive than we anticipated. But when we actually looked at their health data, their true health indicator data, there were some things that were very disturbing. The number that were overweight, the number that actually had high blood pressure. We had one, in fact, who needed to be actually in the emergency room because their blood pressure was so high. There were a third that were already previously diagnosed with diabetes. There were 10 individuals that didn't know that they were diabetic, that through the screening process, we picked that up. When you look at their weight, over half, 55%, were obese. So in self-reporting, they basically said that their health was fair or good or excellent. But it was when you actually did the health assessments that you realized that they had some serious health issues. And again, remember, half of these are pregnant.
It takes at least 3 months for us to really see a significant change in a biometric, for example, a blood pressure or a weight, and so we'll see. Are we going to solve the obesity epidemic with our small little pilot project? No, we're not. Can we make a difference in some lives that are measurable to us? Absolutely, we can.
Public health practitioners are quick to remind me that some of these ideal success measures that we've set forth are not attainable or are not visualized for some time. You don't know that we prevented another heart attack, or you don't know that we've prevented additional childhood obesity.
Success for me is first and foremost that my patients aren't hungry, that my patients are getting food that's helping them get healthy meals on the table. And absolutely, every time a patient comes in that's involved in the study, they tell me how much it means to them.
Replication of a program can happen various ways. The hope is that obviously that this program in some shape or form in Project is replicated and is modified to fit the needs of other areas of the state. But it's also important to us that we sustain this work that we started.
My hope for the program is that, one, it's continued. I think we feel a really big responsibility to continue the program. We see that there's a need, and we see that the participants that have been a part of this program have really benefited.
What is important is the collaboration that started this. It wasn't just a food hub doing this. It wasn't just a hospital. It wasn't just the growers, or it wasn't just an economic development organization, or a nonprofit like Hunger Free Minnesota who's passionate about food security. It was a collection of all of those that made it work. Absent any one of those entities, we could not have done this. So will it work in a rural-urban context? Sure, if you have all those players at the table.
This kind of strategy can really be useful and helpful for the hospital mission, but also the changing landscape around funding in healthcare.
If anybody is looking at what's occurring with reform, hopefully they would see that these kind of things would have some real residual benefits, in lowering the overall cost.
I think that there's some incredible advantages to connecting it to a hospital. Part of that is because of health care systems and insurance companies understanding that food insecurity now is very much tied to health, that it's in their best interest to actually help support this kind of work. So when hospitals start to see that it's in their best interest and a win-win for them, it will be picked up within the hospital. Given the changing way that healthcare is reimbursed now and in the future, this the best strategy they have.
I guess I challenge them. So you're going to let a little place like ours beat you to it and do it better? I guess I challenge you to match it and tell me why you can't do it. If we can do it here, why can't you do it there?
So I would challenge other public health to look at talking to their healthcare system, looking at how can they address food insecurity together.
It's very fun. You see tangible results and you know that what you do made a difference in people's lives. That matters to me. I think it matters to my colleagues. I would challenge them to think about working in this space any day of the week because it's pretty rewarding.